next session and to co-share it with my dear friend Ahmed Al-Halfawi, the dynamo of this meeting. Thank you, Ahmed. Too much work. بس انت you're a bionic man. It's my pleasure to introduce Professor Ahmed Hamada, Professor of Oncology, Cairo University. Unfortunately, Professor Nadia Mukhtar couldn't make it due to special obligations. Professor Ahmed Hamada is going to discuss the oncogenic-driven advanced non-small cell lung carcinoma. الكلام بنفهمه حاجة سهلة أوي. الكلام ده سهل قوي يا دكتور عماد. يعني مستوى ربنا يستر علينا.
بسم الله الرحمن الرحيم. Good afternoon everybody, and thank you Mr. Chair, and definitely I would like to thank the organizing committee who gave me the opportunity to be present in this scientific meeting, and definitely my task will be the oncogenic driven advanced non-small cell lung cancer. ليه مش عامل فول سكرين؟ This is my disclosure. And definitely, since the first description of the epidermal growth factor receptor activating mutation that have been found in the bronchoalveolar carcinoma of the lung since the year 2004, the topic of oncogenic-driven lung cancer has grown rapidly and expanded to encompass a very large number of additional mutation and fusion-related entities. And as mentioned before by the previous speaker, that recent updates to molecular testing guidelines have added several new oncogenes to the initial EGFR and the ALK recommendations, and these include the ROS1, the RET fusion, the MET amplification or mutation, and the HER2 mutation. And definitely the problem with the efficacy of tyrosine kinase inhibitor is the development of resistance and how this resistant pathway will grow and will affect your treatment options with second and third generation drugs now in the market. And lastly, the subtyping of the progression of the disease in oncogen-driven lung cancer should be classified into systemic progression versus oligoprogression disease or CNS sanctuary progression disease that can assist in determining the most appropriate therapeutic approach. So, as we mentioned, that the tissue is usually the issue, not only because of histologic subtyping, but also for molecular analysis. And the choice of the site of the biopsy is of extreme importance, and avoid the bone as much as you can. And definitely, when you have a biopsy, you should determine the EGFR mutation, the ALK, the BRAF, and the ROS1 translocations indicated in all non-squamous cancers, and also in the new era of immunotherapy, we also determine the PD-L1 expression in all non-small cell lung cancer. Rebiopsy at the time of progression, as mentioned, from target therapy help to determine the resistance in EGFR mutated and ALK positive cases, and don't forget the role of liquid biopsy, which when it is positive, it's okay, but when it is negative, you should go for tissue biopsy. These are the cartoon that showed the need for identification and validation of additional markers in the treatment of non-small cell lung cancer, where for the adenocarcinoma, we have approximately 45% unknown mutation, while we have KRAS mutation in approximately 22%, EGFR in approximately 20%, and others. And in the squamous, we have more than 50%, reaching up to 65%, still unknown biomarkers. However, we have a much more fibroblast growth factor receptor in the EGFR and PI3K. So EGFR mutations are found in approximately 10 to 30% of non-small cell lung cancer. It is more common in never smokers, adenocarcinomas, females, Asians, and it is predominantly in the exons 18 to 21. And also we have specific EGFR mutation that are very sensitive and even lead to the acquired resistance to the EGFR mutation, which is the T790 mutation. The first-line therapy in EGFR-mutated non-small cell cancer, these are the time evolution for the timeline for EGFR mutation-positive advanced non-small cell lung cancer. And as you see, since 1997, we have the EGFR inhibitors that enter in clinical development. But the year 2004, we started to have some drugs as the erlotinib and the gefitinib discovered in lung adenocarcinoma. And this continues till we have, by the year 2018, two important drugs, osimertinib, ortegresso, and the dacomitinib. These are the IPAS, which is one of the first trials that have been published by the year 2009 in the New England Journal of Medicine, where they go for a phase 3 trial conducted in Asian countries where they stratify more than 1,200 plus patients with previously untreated stage 3B and 4 non-small cell lung cancer, adenocarcinoma, never or ex-smokers with good performance status, to target therapy, which is gefitinib versus the chemotherapy, the traditional one, the paclitaxel carboplatin. The primary endpoint was PFS and secondary endpoint was overall survival. And as you will see here, for the overall, definitely gefitinib is much better with a statistically significant p-value, but for the EGFR mutation, the two curves are quite separate after 4 months in favor of gefitinib. But if you have a negative EGFR, definitely at that time, chemotherapy is much better than target therapy. These are the list of the EGFR mutation-positive studies in non-small cell lung cancer, with definitely a median PFS improvement if you have an EGFR mutation-positive in favor of the tyrosine kinase inhibitors. However, the overall survival is not yet increased. The relative frequency of acquired resistant mechanism to EGFR TKI is very important by the T790M, which constitute approximately 60%. However, we have another mutations in the range of 1 to 4%. And this will game with the AURA3 trial, where they go for osimertinib, ortegresso versus platinum pemetrexed in EGFR T790M positive advanced non-small cell lung cancer. And as you see, the PFS was in favor of the osimertinib 10 versus 4.4 months. And this led to movement of the osimertinib to the first line by the FLORA study, where they show again a PFS in favor of the osimertinib 20 months versus 10 months with a high hazard ratio of 0.46 and statistically significant p-value. And when we go to the subgroup analysis, it favors almost all the subgroup, whether you have an EGFR mutation at randomization or by liquid biopsy, or even CNS present or absent. And the overall survival, again, was in favor of osimertinib with a hazard ratio of 0.63%. However, the p-value less than 0.0015 have been required for statistical significance at current maturity. Concerning the CNS, as you say, osimertinib work if you have a CNS metastasis at baseline or without CNS metastasis at baseline, with definitely improvement in PFS in favor of the osimertinib. Definitely, this on the toxicity profile, that we have more dermatitis, more elevated liver enzymes when you go to osimertinib versus the standard of care. So what about sequencing? Definitely, you can go, if you have a negative T790 mutation, you can go for the first generation erlotinib gefitinib with a 10.2 months PFS. If you have a positive, you can go for the osimertinib that at 10 months also. And for all patients, if you start by osimertinib at first line, you can achieve approximately 19-month PFS. Also, we have another drug, the dacomitinib, in EGFR mutated advanced, and also it showed a median PFS of 15 months versus 9 months, and it is FDA approved, but definitely it is more toxic and not active in the CNS with shorter PFS than the osimertinib. These are the comparison in 2019 with improvement in overall survival starting to be seen. However, the main issue is that you have a PFS improvement and the toxicity varies between the drugs. So definitely, if you have a similar drugs, you can choose upon with the PFS improvement, overall survival improvement, and toxicity. What about the non-EGFR TKI approaches? Definitely the checkpoint inhibitors or the immunotherapy. And we notice that definitely for patients with mutated EGFR, they do not respond to the immunotherapy. However, the EGFR normal or wild type, still they favor the PD-1 and PD-L1 inhibitors. So we have definitely some studies that showed no response, and they stopped the study due to the futility when they have an EGFR mutated and going to immunotherapy. So never go to immunotherapy if you have an EGFR mutation. And also we can have the chemotherapy can add to in EGFR mutation positive. We have two trials, the carboplatin pemetrexate with or without bevacizumab, which is an anti-angiogenic, and definitely it is the standard first-line chemotherapy for non-squamous non-small cell lung cancer with EGFR mutation. However, again, the Keynote 189 first-line carbopemetrexate with or without pembro in metastatic non-small, they improve overall survival and PFS with the addition of pembro. However, patients with EGFR mutations have been excluded from these phase 3 trials. Again, we have by the ESMO this year that we have the Empower 150. They add atezo to carbopaclitaxel and Beva in advanced non-small cell lung cancer. And as you see, definitely we have better improvement in PFS, overall survival, also with a good hazard ratio. And definitely this trial includes small subset of EGFR mutation positive patients, approximately 59 patients. However, the FDA label for atezo does not include EGFR or ALK alteration. So if these EGFR mutated drugs definitely improve the PFS and some of them improve the survival in stage 4, what about the early stage? Definitely we have 3 trials, the BR19, the radiant, and the adjuvant, and definitely we didn't have any evidence to support adjuvant EGFR TKI in the BR19, and you have some early disease-free survival benefit, but not overall survival in the other trials. So still an open questions, and we should wait the phase 3 trials of Alchemist, whether you go for erlotinib for 2 years in EGFR mutated non-small cell lung cancer in the adjuvant setting, and the ALK rearrangement also crizotinib versus placebo. So my first take-home message, that in treatment of EGFR mutated positive non-small cell lung cancer, osimertinib is the new standard of care based on the FLORA study, and definitely we should have new targets for acquired resistance to osimertinib that have been investigated. Checkpoint inhibitor monotherapy shows minimal benefit in EGFR mutation positive non-small cell lung cancer, and in early stage there is a prolonged disease-free survival, but no overall survival benefit has been shown. However, we should wait the Alchemist trials. What about the ALK translocation, which occur approximately in 7% of the patient? We have a lot of drugs in the ALK rearrangements that had been identified in the non-small cell lung cancer, starting by the crizotinib and going to the alectinib, brigatinib, and lorlatinib. These are the ALEX trial, where they compare alectinib versus crizotinib, and again, alectinib have a better median PFS that had been not reached versus 11 for the crizotinib, with a very good hazard ratio and statistical significant p-value. And this is the updated analysis. Again, it goes for in favor of alectinib, and look to the median PFS, 35 months versus 11 months, with a hazard ratio of 0.43, and also for the overall survival, although it is better. And for the alectinib versus crizotinib, however, it is not reached for the 2 drugs, and the hazard ratio is only 0.76. Concerning the time to CNS progression, definitely it was in favor of the crizotinib, where we have definitely 58% for the 1 year and the 31% for patient without CNS metastasis at baseline. Alectinib in patients with non-small cell lung cancer and symptomatic or large brain metastasis, we have these cases, as you see, at the baseline. for patient 1 and patient 6, and you have 4 weeks of alectinib, and as you see, the lesions start to decrease in size, and by 15 weeks of alectinib, we didn't have any of the lesions, just some edema from the brain tumor. Also, the leptomeningeal carcinomatosis responded well to the alectinib, and because of this, I consider alectinib as the first line in the ALK-positive non-small cell lung cancer. Also, we have another drug, the brigatinib. Again, it was in favor of brigatinib versus crizotinib concerning the PFS and also concerning the PFS by CNS metastasis. So the biomarker recommendations definitely should go for EGFR, ALK, and BRAF, ROS, and PD-L1 and TRK. And this is the second take-home message, that alectinib is preferred definitely in the setting of ALK translocation. What about the second line? Definitely, again, we have the lorlatinib through a phase 2 study that showed definitely a very good median PFS of approximately 7 months and the median duration of response for more than 6 months in 47% of your patients. However, definitely we have grade 3 hypercholesteremia and the hyperglycemia, and also we have the edema and peripheral neuropathy and the weight gain. So definitely you should take care of the hyperlipidemia and the mood and the cognitive effects with lorlatinib. This is a limited role for other second-generation ALK TKI after progression of disease on first line. We have also the ceritinib and the brigatinib. What about the role of chemotherapy? Should we use chemotherapy in ALK positive? Again, this was the PRO5, 1014, and the ASCENT-4, where they showed definitely that the target therapy, crizotinib and the ceritinib, are more effective in the ALK positive non-small cell lung cancer than chemotherapy. So again, lorlatinib is the third treatment for ALK positive who progress on first line alectinib, but definitely you should take care of the hypercholesteremia and the hypertriglyceridemia and the cognitive side effects. So definitely nowadays we have a personalized therapy in advanced stage non-small cell lung cancer, where we move from the 1970 till today with chemotherapy based only on the histologic subtype, which is not nowadays the standard of care. However, we go for the molecular analysis with the EGFR, ALK, ROS, and BRAF to the target TKI therapy, and also in the era now we have the checkpoint inhibitors, which are anti-PD-1 and the anti-PD-L1. So definitely, to sum up, target molecular therapies are now standard of care for oncogen-driven non-small cell lung cancer with a good clinical benefit and minimal toxicity over chemotherapy. So because of this, we go to the molecular subclassification. The role of immunotherapy in patients with molecular alteration is still unclear, and we should not use till now the immunotherapy unless we combine it with chemotherapy. And the blood-based genotyping has gained interest in the diagnostic and resistance monitoring setting for patients with non-small cell lung cancer, and these are the treatment algorithm where we go for the Tagrisso for the EGFR positive tumor, and also the ALK. We have the alectinib followed by the ceritinib or crizotinib, and if they progress second line, we have the lorlatinib. And thank you very much for your kind attention.
Thank you very much, Dr. Ahmed. I don't know if there is any questions from the floor, but I will start with one. As a bronchoscopist, so I don't know whether it's a small, non-small. I take biopsies from a lesion.
Yes.
What would you want me to send for the pathologist?
I think he should, after the biopsy and the confirmation of the histology, you should go for the non-small for the EGFR, ALK, ROS, and PD-L1 testing. And also nowadays for the small, we go for the RAS testing and even for the PD-L1 testing. So after the histologic confirmation, you can go for molecular analysis, not from the first step.
On the biopsies that were obtained?
Yes, yes.
Yes, because you cannot go back and rebiopsy.
No, the rebiopsy is only due upon progression. If you have a patient and you give him the treatment and he did not respond to the treatment, you guess what is wrong. So I will rebiopsy, because definitely we have also a problem with the biopsy because the yield of the biopsy is too small in order to have histology molecular. So because of this, we go also to the liquid biopsy nowadays.
And I would ask for the pathologist to do ALK.
Histologic confirmation,
Histological
what is
first.
the type, and if non-small cell lung cancer, you can go for EGFR, ALK, ROS, and PD-L1.
Very good. Thank you very much.
Thank you.
Dr. Hela.
After using. What about the opportunistic infection after using this immunotherapy introduction in treatment?
Opportunistic infection?
Yes. This
After?
long-term treatment by immunotherapy, I know, but we should follow up the patients for many opportunistic infections.
Definitely, but immunotherapy will not cause
there is a risk-benefit ratio.
Yeah, the chemotherapy can go for opportunistic infection, but in
biological treatment per se, high incidence of opportunistic infection in biological more than chemotherapy, classic chemotherapy.
In immunotherapy?
Yes.
No, we don't have opportunistic infection. We have an itis, inflammation, which means that we have hepatitis, colitis, you can have hypothyroidism, you can have hyperthyroidism. So it is due to the immune suppression, and this will be treated by steroids.
Incidence of tuberculosis, for example.
No, the chemotherapy causes the opportunistic infection, and the opportunistic infection.
Immunotherapy more.
Immunotherapy will not cause opportunistic infection. Why? Why?
Because many patients, for example, when using treatment for hepatitis C, biological treatment, we follow up these patients. We found more increase in percentage of tuberculosis in these patients. So
no,
I think long-term using biological treatment, we should care. We should care.
Definitely, you should care, but it is not only tuberculosis. We notice that patients that have been treated for HCV, we have more cases of HCC. And definitely it is because of the tumor microenvironment that have been changed with the antiviral treatment. But for immunotherapy, we have the itis syndrome, and we didn't have opportunistic infection. Opportunistic infection is very specific infections that can occur in hematological malignancies in some cases of chemotherapy.
No increase in incidence after using
no.
Okay.
No.
But the second question here was about different mechanisms of immunotherapy. There is many drugs for immunotherapy. There is different on
the immunotherapy is based on what is called the checkpoints. The checkpoints, these are the checkpoints that have been enhancing the T-cell activity. So if I break these checkpoints by anti-PD-L1 and the anti-PD-1, this will remove the break from the T-cell that will act against the tumor by the tumor-infiltrating lymphocytes.
Thanks.
Thank you.
One more question.
Thank you, Dr. Ahmed, for this illustration. First point, you say in the lecture, liquid biopsy is okay, with no need for tissue biopsy. If it is available for tissue biopsy, we cannot do it if we depend on the liquid only?
It's one tool if you didn't have an access to a tissue biopsy. But even if I have a liquid biopsy circulating DNA and it is negative, I should go for tissue biopsy.
Okay. Blood-based genotherapy, can you demonstrate this point?
It is the molecular subtyping with EGFR, ALK, ROS, and PD-L1. It is genetic molecular testing.
Genetic.
Yes.
Thank you.
Thank you.
Thank you very much, Dr. Ahmed, for the nice talk. And we invite Dr. Awala Khurshid. She's a professor of medical oncology for National Cancer Institute and the head of thoracic oncology department there. She will talk about non-oncogenic driven mutation in advanced non-small cell lung cancer role of immunotherapy.
Have a mic, guys. Thank you very much for the introduction. Let me take this mic. Okay. First of all, it's quite an honor to be here in one of the biggest pulmonology congresses in Egypt and in the Middle East. And it's a great opportunity to show how we work in multidisciplinary treatments. And I'm sorry that we're saying a lot of drugs. In my lecture, I'm not going to be talking about the drugs, we're talking more about the mechanism of action, and I will show you how the paradigm has truly changed in the management of stage 4 disease. So when you look at the overall survival of stage 4 disease, the overall survival is 0. 5-year overall survival is 0%. We cannot cure those patients. Remember this. So truly our goal of treatment is to improve the symptoms of the patients, but not only this, we need to improve the quality of life of our patients with the least side effects that we can get. So evolution of treatment, as you heard, we used to treat this disease as one disease, and it was mainly based on histological subtyping. However, now we treat our patients based on molecular subtyping. As you heard, we have drugs that when given to those patients who have an oncogenic-driven mutation, the overall survival can reach 4 years. This is something that we never had before. However, almost 47% of our patients do not have this oncogenic-driven mutation. They're not going to have the EGFR or the ALK. So what can we do for them? So for a very long time, what we could do was only chemotherapy, and whichever chemotherapy we gave, the overall survival was less than 1 year. And then we had some breakthrough with giving pemetrexed based on histological subtyping, adenocarcinoma, and it seemed that pemetrexed cisplatin was better than what we were using, but again, the overall survival was only 1 year. And then we tried the maintenance treatment for those patients, minimal improvement in survival. Again, it was only 14 to 16 months. So truly an unmet need. You can see whatever we do, the best that we can have is an overall survival which is less than 1.5 years. And then we had the era of immunotherapy, and we had 2 Nobel Prize winners last year, Dr. Allison and Dr. Honjo, based on their amazing work for immunotherapy. They showed that immune system does have a role in protection against cancer, development, and growth. And it passes through 3 phases. An elimination phase, where antigens are detected, the lymphocytes eliminate the tumor cells, and an equilibrium phase, where there is no growth and there is dormancy of the cancer, and then an escape phase, where the tumor starts to grow and outgrow the immune system. So how does elimination of cancer occur? For that to occur, you need to have tumor antigens that are presented to the dendritic cells, and when they are presented to the dendritic cells, this leads to activations of the T cells. Activated T cells, when they proliferate, they then attack the tumor cells. So you need basically 3 important things. An antigen, a tumor antigen that is present, you need to have activation and proliferation of the T lymphocytes, and you need to have a T cell that is able to target the tumor and to destroy the tumor. However, we know that the lymphocytes, they have different stimulatory signals, such as the CD28, and they also have inhibitory signals, such as the CTLA4 and PD-1. And this is important. Normally, we have both signals that are there, and the inhibitory signals are important to check the immune system, to prevent overriding of our immune system. For the T lymphocytes to be activated, it not only needs the new antigens to be presented by the antigen-presenting cells, however, it also needs to have stimulation of the CD28 by B7 in cancer cells. However, because the cancer cells are expressing the CTLA4, this leads to, which competes with the B7 for CD28, this prevents the lymphocytes from activation. So this prevents lymphocytes from being activated and proliferation. However, we do have anti-CTLA4 inhibitors such as ipilimumab and tremelimumab. Now, at the effector site, when a T lymphocyte recognizes the tumor, it should be able to destroy it. However, tumors are quite smart, and they have PD-L1 expression. And PD-L1 expression, when it combines with PD-1, an inhibitory molecule in the T lymphocytes, it causes energy and it stops the immune mechanism. We do have drugs that target the PD-1, and we have drugs that target the PD-L1, several of them, and we do have them here in Egypt. We have the nivolumab, we have the pembro, we have the atezolizumab and durvalumab, and we've been using them for some time. However, we check for PD-L1 expression, and the higher the PD-L1 expression, the better is the response to the drugs that we are giving. So PD-L1 expression is done by immunohistochemistry, and we typically say that it's a high expression if it's more than 50%. Now, non-small cell lung cancer is characterized by very high mutational load. It is one of the highest, and the reason is that smokers do have a fingerprint mutation due to tobacco exposure, and this mutation leads to creation of new antigen. So this is an ideal disease where you can truly use immune checkpoint inhibitors for treatment of this disease. And we have seen that for patients who are PD-L1 more than 50% expression, when we were giving the standard of care chemotherapy compared to a single agent immune checkpoint inhibitor, the progression-free survival was much higher. The response rate was 45% compared to 30%. But look at that. Overall survival in stage 4 disease was 30 months compared to only 14 months. This is something we've never seen before. And this is using a single immune checkpoint inhibitor, not even combined with chemotherapy, for patients who are PD-L1 expressing more than 50%. And this was seen in patients even and this significant improvement in survival was seen even though 60% of the patients in this trial received second-line immune checkpoint inhibitor. So this was practice-changing for us, and this led to pembrolizumab being the standard of care for any patient expressing PD-L1 more than 50%. However, this is only present in 30% of our patients. So only 30% will express PD-L1 more than 50%. So what can we do for the rest of our patients? And this led to trials that were looking at what about combining chemotherapy with immune checkpoint inhibitors or vascular growth factor inhibitors. And contrary to what we used to think, that chemotherapy will suppress the immune system, this is not true. Actually, chemotherapy and anti-angiogenic drugs, they actually enhance the immune response, they increase the T effector function, they increase the T cell penetration, and they eliminate the immune suppressive cells. And we had another important practice-changing trial, which was the Keynote 189. First line for stage 4 disease who are regardless of their PD-L1 expression, and those patients didn't have any oncogenic-driven mutation. Chemotherapy, the standard of care, which we all use, with or without pembrolizumab, combining immune checkpoint inhibitor with chemotherapy. And in this trial, they did include patients with liver metastasis, with brain metastasis. Almost 20% had brain metastasis. And there was a significant improvement in response rate. Adding pembrolizumab to chemotherapy improved the response rate 50% compared to 20%. And more impressively, overall survival was not reached compared to 11 months. And progression-free survival was doubled. So quite impressive results. And this was seen regardless of the PD-L1 expression. Certainly if you have higher PD-L1 expression, the survival is better. Yet we still see this impressive overall survival even in those having PD-L1 negative disease. Now, even in those patients who had liver metastasis, patients with liver metastasis, they do quite poorly with chemotherapy. Their survival is less than 6 months. When you add pembrolizumab to chemotherapy, their survival has doubled. It's 12 months compared to 6 months. And impressively, in those patients who have brain metastasis, their overall survival was actually 20 months compared to 7 months, with an impressive hazard ratio of 0.4. And then we had an interesting trial that looked at what about giving a CTLA-4 inhibitor and a PD-L1 inhibitor. This is the Checkmate 227 trial. It randomized patients to a combination of nivolumab, ipilimumab, and chemo compared to nivolumab single agent. And in this trial, again, the combination showed significant improvement in overall survival and progression-free survival. And this can be an option that we can use for our patient, an option without any chemotherapy. So non-oncogenic non-small cell lung cancer, now we treat patients not just based on histology, we do treat them based on their PD-L1 expression. If it's more than 50%, you can give a single agent immune checkpoint inhibitor. If it's intermediate, 1 to 49%, then either you can use an immune checkpoint inhibitor with chemotherapy, with or without anti-angiogenic drugs. And for the negative patients, we can go for chemotherapy. We can go for the Nivo-EP combinations. And just to show you, overall survival that has truly doubled. when you are giving a single agent pembrolizumab, whether it's squamous, whether it's non-squamous. This has never been shown before in the stage 4 disease. Now for the second line treatment, sadly, not all of your patients are going to go for second line treatment, and you're going to be losing 30% with second line and with third line. And we did not have a lot of options, and the options that we had were really chemotherapy, docetaxel or pemetrexed. Responses were very poor, 9%, and the overall survival that was in the ranges of 6 to 7 months. So again, unmet needs, and we had some trials on new anti-angiogenic drugs, nindatinib and ramucirumab. Both of them, the trials did show some significance. However, the magnitude of benefit was so low, it was only 1 month. So then we had the options of immunotherapy, and I think immunotherapy did change the way that we treat our patients, even in the second line, and we have 3 drugs that were shown to be quite impressive compared to chemotherapy: nivolumab, pembrolizumab, and atezolizumab, all of them showing significant improvement in overall survival compared to the standard of care chemotherapy that we give. And more impressively is that we have actually data, 5 years follow-up for patients who have been taking nivolumab for 5 years. And look at that, we have a 5-year overall survival of 16%. Remember, in the beginning, I showed you that the 5-year overall survival for stage 4 disease is 0%. We are actually having 16% of our patients surviving for 5 years. So this is actually quite a paradigm change in the treatment and impressive results. And this was seen regardless of whether it was squamous or non-squamous. And you can see that with docetaxel, second line, overall survival just 7 months, with a 5-year survival of 0%. And if you give the immune checkpoint inhibitors in second line, the overall survival, you can actually have an overall survival of 5 years of 16%. So yes, you can see that patient with massive metastasis who can actually have this response after immune checkpoint inhibitors. This does happen, and we've seen those patients. However, this is not without side effects. We have seen unconventional toxicities, and this is what we were talking about. We were talking about having the itis. We can have pneumonitis, especially those are patients with COPD. Those are patients who are smokers. Those are patients with a lot of chest problems. And some of them are patients who already received radiotherapy before. So having pneumonitis is a problem that we are facing. How to manage? We actually need the pulmonologist help to help us in this management. We typically treat those patients with steroids, but definitely those patients need much, much more than that. So roadmap has changed from starting with 9-month overall survival to approaching 3 years with the new treatments based on personalized treatment. And with the impressive results of immunotherapy that we're seeing, we're actually now using immunotherapy in the earlier stages, and we've had data that giving 2 cycles of a PD-1 inhibitor prior to surgery, you can have these impressive results, and you can have actually major pathological responses in 45% of your cases. And combining, and more impressively, combining immune checkpoint inhibitors with chemotherapy before surgery in T4N0 to 1 patients. Again, it was a phase 2 trial, but it was quite an impressive trial where Nivo was added to chemotherapy. And look at that, pathological CR of 60%. So quite impressive data that we're having now, and quite dynamic, impressive effects that we're giving for our patients. Now, even in the stage 3 disease, it is now standard of care to give immune checkpoint inhibitor, durvalumab, to patients who have received concomitant chemoradiotherapy and still had residual disease. Those patients should be treated with immune checkpoint inhibitor maintenance for 1 year, because those patients do have an impressive 3-year overall survival that is not reached, median that is not reached, compared to 29 months. Treating stage 4 disease as a multidisciplinary, it's a multidisciplinary treatment. It involves the oncologists, the pulmonologists, the surgeons, together, of course, with the backbone radiologists and the pathologists. And yes, we can have those patients, and I ask the pulmonologist, whenever, please, you have that patient, it is not as grim as you think. We can change him to this. However, we need your help in the middle to be able to manage all the side effects that this patient is going to have with the new treatments. And just to end, I'm quite proud that we started this collaboration of multidisciplinary treatment with the pulmonologists, with the surgeons, a few months ago in the Oncothoracic International Congress. The second one will be held in the 1st and 2nd of October. Let me tell you that we have at least 5 eminent pulmonologists who are presidents of that meeting. Professor Dr. Tariq and Professor Dr. Ahmed Halafawi are all, they are presidents in this meeting. And thank you.
Thank you, Hala. يعني real wonderful presentation as usual. So elegant presentation. I think I'm going to be an oncologist. I don't understand what you're doing, of course. Our role as pulmonologists, let me tell you our real life situation. We diagnose the patient after bronchoscopy and we send it to the oncologist. Give me your practical opinion. How do you deal with the patient in this black side of life? Do you tell him, for instance, like the Americans or Europeans sometimes, you have 3 months ahead, you have 12 months ahead. How do you deal with your patients?
So, being an oncologist is actually it's a difficult branch because you need to not only be an excellent doctor for your patients, quite updated and quite knowledgeable, but you have to be a psychologist and psychiatrist too. So we tell the patient the truth, and the truth is that we are truly improving the quality of life, we're improving the symptoms of the patients, and we're not going to give the patient a treatment that's going to, that he will not benefit from. So when we have this impressive data of having a treatment that will give my patient a survival of 3 to 4 years, by all means, I will offer this to my patient. Now, we are seeing now that 15% of our patients are actually surviving at 5 years. So this is a hope that is there. 15% at 5 years are surviving with the treatment. So I've had a couple of patients who were diagnosed with non-small cell lung cancer with initial brain metastasis. Do you know how long that they survived? One of them survived for around 5 years. And actually 2 of her daughters got married. And the other one is actually, he's still there and he's surviving. And those are oncogenic driven. Now the impressive data is really in the non-oncogenic driven because we didn't have any options for those patients. Now, allowing and having something, having your immune system to fight that disease is actually quite impressive because it is becoming truly personalized. And even in those patients, 15% are alive at 5 years. So, I mean, it is truly a paradigm change, and it's truly impressive. And we really wanted to come to convey this important information to our colleagues, the pulmonologists, because typically the patient, you see the patient first. So it's important that you know what can we offer, what are the things that we can offer for those patients. Now, if the pulmonologist, knows that the chemotherapy will offer the patient less than a year, and the patient is having some comorbid conditions, I have seen some pulmonologists who would tell the patient, well, you don't have a lot to live, and we advise you to stay at home. This does happen. So we need to change the way that we see our patients, the way that we talk to our patients, and we need to know what we can offer for those patients. And again, I thank you for giving me the opportunity to be here today with you.
Thank you so much. Any questions? Yes?
Yes, please.
Professor Yasser?
Thank you, Dr. Aoun, about this illustration, but according to us as surgeons, we make us in dilemma. Shall we refer the patient first to take some treatment before resection if we decide to resect it? Or shall we not touch the patient and just follow by your treatment? And the second point, what about earlier stages of immunotherapy? What's meant by earlier stages of immunotherapy? Thank you.
So one of our biggest dilemmas is the stage 3 disease, what to do for stage 3 disease. And typically what we do, and the dilemmas are based on your N2 disease. Would you go for surgery if this is a single station or you're having a microscopic infiltration of the N2? Or would you give neoadjuvant chemotherapy alone? Or would you give neoadjuvant chemo and radiotherapy, the triple regimens, for those very young, healthy patients? Now, the aim of treatment is truly to downstage your N2. If you're able to downstage your N2, you can cure some of those patients. And till very recently, I mean, I was very impressed with the German data, which was showing that the triple therapy is actually quite impressive. You can really downstage almost 40 to 50% of the N2 diseases to become N0. And provided that you don't go for pneumonectomy. So if you're going for lobectomy, left side, you are actually curing some of those patients. And the best impressive results were seen for those patients since you're a surgeon. Now, the paradigm is changing a little bit, and I'm seeing more and more looking after the Durva data. They're saying, well, no, let's go for concomitant chemoradiotherapy and then give the Durva. Durva is not cheap. It's a very expensive drug. And you're going to give it for 1 year, and the survival, again, it's going. We're talking about, yes, it was not reached at 3 years, but still, we are losing patients. If I can have my patient go for surgery, this will be the best thing that I can do for my patient. And we're actually having data that is asking about, should we go for immunotherapy after the surgery? These are new trials that are ongoing now. So if you can go for surgery, this is the best thing. And the question is what to give after surgery, because till now we don't have any consolidation after surgery. We don't give chemotherapy after surgery. Now, if the patient goes for chemoradiotherapy, and again, we didn't have any option for those patients, we go for immunotherapy. But in my opinion, the most impressive is giving immunotherapy before surgery. The pathological CR is out of this world, but yet again, these are only phase 2 trials. We have to wait for the true data from the phase 3 trials to come. But it is looking very promising. You know, I mean, 2 cycles of immunotherapy and have this. So we will probably not have the debate of chemo or chemoradiotherapy anymore.
Thank you so much, Ola. And I think it's time to close a very interesting topic. And may I invite the chairperson for the next session, Professor Hantira, Professor Asim Aisawi.